others to accommodate for that. Aspiration can happen during the procedure because you are stimulating the pharynx, which obviously if the gag reflex is present, you may run into trouble there. Now, once you place the tube in, you have to maintain the patient on this because most patients don't actually like to have a tube inside the tube, or any foreign body for that matter. So how would we do that? Well, we have to think about pain medications, sedatives potentially, all of which have their own set of consequences, potential consequences. There's an increased risk of infection now. Remember, ventilator-associated pneumonia. The risk is highest in the first 5 days, and then it decreases. But every day that the patient is receiving this form of support, there is an increased infection risk. Why? Because we've now bypassed the normal filtering mechanisms of the upper airway with a hollow tube that has no intrinsic immune protection. Okay. Then this phenomenon of ventilator-induced lung injury, where because we can't really predict how well the lung is going to respond in this inflamed and damaged state to blasts of air that come in. So the idea being that if we over-distend the lung with the air that we're giving, that can cause damage. If we allow too much collapse of any individual units of the lung, or causing atelectasis, atelect trauma, that can be a problem. There may be barotrauma on a macro level, which actually doesn't happen very much, such as pneumothorax, mediastinum. Oxygen toxicity can also happen. So those are things to think about, and leads into why we use lung protective ventilation strategy, which isn't really a topic for this talk today, but we will be talking about it elsewhere. Okay. There are hemodynamic compromises not only from the medications to maintain patients to be comfortable and tolerating this form of support, but also potentially from abnormalities of the pump function now that we're on a ventilator. For example, PEEP or auto-PEEP can have hemodynamic consequences in certain subsets of patients. Okay, not all, but especially with COPD patients who have increased or reduced airway resistance. Increased airway resistance where they cannot exhale, they need a higher expiratory time. There may be a phenomenon of auto-PEEP where now you have increased alveolar pressures that are now transmitted to the extra pulmonary space where the vasculature lives. Okay? All right, now once we've taken the patient, we've decided the patient has improved enough to remove the endotracheal tube, there are still some issues with taking the tube out. What can they be? Well, because we've shoved this thing through the vocal cords, and they may be irritated. They've been sitting there. So there may be laryngeal edema. If the tube has been in for a significant amount of time, usually more than 2 or 3 weeks, you can have independent closure of the trachea or any of the subglottic space that can lead to problems. There may be hemodynamic factors when you are taking patients off medication or even just removing the tube. Remember, airway resistance goes up now because now you're not bypassing the normal upper airway, so that may lead to increased stress or increased work of breathing. There is a phenomenon of delirium that happens in pretty much, well, I would say the majority of intubated patients that is irrespective of the indication for intubation. And that is definitely a increasingly recognized phenomenon that is targeted with treatments, both pharmacologic and non-pharmacologic, which we've talked about elsewhere. Okay. So initial setting. So if we start with our patient, I am talking about Drager's edema. Well, we're not going to talk about that so much here, but you have this blood gas on non-invasive pressure, right? Patient is intubated now, patient is put on the ventilator. What we're going to set are the following things. The mode is the first thing, because without the mode, it'll determine what the other parameters are. So the first decision is what mode. And in basically all cases, we're going to choose assist control. Okay? Why? Because usually patients are paralyzed, sedated and paralyzed. And usually when you have intubated the patient, you want to have complete control. So you don't want to have someone on a spontaneous mode where patient effort is determines the amount of breath that is received, you want to have complete control over every single breath that the patient is receiving. Okay, so AC, or assist control, is the mode. The tidal volume ideally will be set at a lung protective range, which is basically 6 to 8 cc's per kilo predicted body weight. And I say predicted because that's based on height, not on actual body weight. And the reason is because the chest cavity depends on height more than it does the actual body weight. Think of your short, fat person versus the tall, thin one in terms of what the lung capacity will be. FiO2 will be 1 or 100% basically, because again, you want full control. And PEEP is just arbitrarily set at 5 unless there's another indication to do so. Once you've set the mode, then that'll determine what these other parameters are, including respiratory rate, FiO2, pressure support, flow, PEEP, whatever that is, depending on what the mode is. Okay? Predicted body weight here, I note, is based on height. Okay, so if you haven't heard it from me already, I harp on this all the time. So we always measure patients in the bed for their height. Okay, asking patients' families or asking the patient about their height is not the worst thing, but often people are wrong and they like to be taller than they actually are, and so we end up just going through it takes an extra minute, but we do it and we put it to rest. Okay. So how does the breath given from the ventilator, this machine? Well, there are a couple of different things that the ventilator, as a smart machine, thinks about. First of all, the breath is triggered by something. So what actually initiates the breath? Well, it's either time dependent or it's pressure or flow dependent, meaning that either the ventilator decides or the patient decides. If the ventilator decides, it's at every set amount of time there's going to be a breath. Okay, and that's again a mandatory. It's going to be more of one of the mandatory modes, meaning AC, assist control. If the patient decides, usually they're going to be generating themselves with their own effort a pressure or a flow that the ventilator will recognize, and then they will transmit the breath from that standpoint. Okay? So that's one thing to think about. What is it going to do when it recognizes that the trigger has been activated? Okay? How is it going to give the breath? What is control? Okay, so this is all, we're all talking about inspiration at this point. So the breath is coming in to the patient. You can either give it with flow, or meaning volume, or you can give it by pressure. Okay, because you can't measure flow very well. So it's either volume or pressure. So we have volume control, where every inspiratory breath is a set amount of volume, or it's pressure control, where the ventilator is giving the breath according to a certain amount of pressure. Okay? Again, this is more of a mandatory mode scenario. So AC, assist control. So fixed volume target for each breath. Pressure control is a fixed pressure target for each breath, not to be exceeded in either case. Okay? All right, then it decides when to exhale. So you got the breath in. Now how is it going to know when to let the breath out? So get rid of all the CO2. Well, it depends on the mode. Okay, so it can either be time, flow, volume, or pressure. So if you're in volume control or AC, after every breath, you have a certain amount of volume that comes in, and after a certain amount of time, it will come out. If you're on pressure support or a spontaneous mode, it depends on what the patient decides in terms of the flow rate, the decrement in the inspiratory flow, okay? Or how fast the pressure rises. It depends on a number of different factors, okay? But if it's volume control, the exhalation is after the volume is achieved. Pressure control, exhalation after a certain amount of time or the pressure is achieved. Okay? All right. Then there's another thing that's present all the time. It doesn't matter if the breath is triggered, or it's inspiratory time, inspiratory breath, or an exhalation phase of the breath. It's there all the time, and that's PEEP. Okay, so that's positive end expiratory pressure. That means at the end of the breath, you still have an amount of positive pressure that's inside, that you're actually giving the patient. It's externally applied. That's PEEP. Now, there are a lot of terms that are thrown around. CPAP, EPAP, all these things. For the sake of simplicity and to be current, we don't use CPAP anymore. That's an outdated term, okay? And EPAP is only specifically used on a BiPAP mode of non-invasive positive pressure. So the BiPAP machine. BiPAP is actually a machine that delivers non-invasive positive pressure ventilation. So you can actually have NIPPV without BiPAP. Okay, does that make sense? And in that case, you don't set an EPAP at all, it's just the PEEP. So I would just stick to simplicity and say that it's PEEP. So that's present all the time, baseline. Okay. Talking about modes quickly. So AC is formerly known as CMV. Why do we call it formerly known? Because CMV is controlled mandatory ventilation. That means every breath was controlled and mandatory. Well, that's not the case in AC. AC is assist control. So assist means that the patient is actually generating the trigger, and control means that the ventilator is deciding whether or not the patient wants it or is triggering or not. Okay, so that is the current nomenclature for in terms of the most mandatory mode that we have. Okay, so I'm not going to talk about that because we don't have triggers. Every breath is the same. That's the key element in terms of understanding modes. I like to differentiate it just really simply. Either the ventilator does most of the work or all the work. Well, we'll say most of the work, or the patient does most of the work. If you are in assist control, the ventilator does every breath the same, whether the patient triggers it or not, and they have a set amount of breaths. But every breath is the same volume or pressure, depending on what you set. Same FiO2, same PEEP, same flow rate, same, all that is the same, okay? You cannot set the pressure, well, anyway, all that is the same. And every breath is the same. It's all mandatory from the ventilator. On the other hand, if you have pressure support or spontaneous, the patient decides the other thing is the respiratory rate is also set. Patient decides the respiratory rate. Patient decides the tidal volume. The FiO2 is set. But the pressure is also determined by the patient, him or herself. So it's the least effort done by the ventilator. So you got most done by the ventilator and least done by the ventilator. And then you've got a bunch of stuff in the middle which is kind of a combo, doesn't really solve one thing or the other. Okay, so in understanding the modes, just think of it very simply. The ventilator does the most and the patient does the least. Or, on the other hand, the patient does the least and the patient does the most, and the ventilator does the least. This one being assist control, this one being pressure support or spontaneous mode. And then in the middle, there's SIV, there's APRV, there's all these other things. Okay? All right. So, as we were saying, A is assist, pressure is initiated by the patient, triggered control is C, without the patient. Volume control, the tidal volume is set, respiratory rate set, FiO2 set, PEEP set, but the PIP, or the peak inspiratory pressure, is not set. Why? Because in volume control, you don't care how much pressure it takes, you're going to give the breath until the volume is finished. Okay? So you cannot set the pressure when you have volume control. Okay? On the other hand, if you have pressure control, you set the pressure, you set the respiratory rate, you set the FiO2 and the PEEP, but you cannot set the tidal volume. Because you're only going to allow enough volume to reach that pressure, and then you're going to stop. So it depends on a little bit like the patient's effort. If the patient is taking an effort as the breath is coming in on pressure control, then the alveolar pressure will be lower because they're generating a negative pressure from their chest wall expansion, as opposed to someone who is breathing against the ventilator, in which the pressure will go up much higher. Does that make sense? So there'll be less volume in the second case coming in, and more volume in the first case. It's like if you basically put your head out the window when you're driving the car. Because if you take a breath in, it's much easier to get much more air inside, as opposed to you trying to breathe out and having that air pushed into your throat. Does that make sense? Okay. So both of these cases are assist control, though, where the ventilator is doing the maximum effort, and the patient's doing the least effort. Now, on the other hand, you have spontaneous mode, or pressure support ventilation, where, and again, this is formerly known as CPAP. We don't use that term anymore. It has expiratory flow cycling. So basically, you set a pressure support, you set an FiO2, and you set a PEEP, like you always do, but you cannot set the respiratory rate, and you cannot set the tidal volume, because it all depends on how much the breath, patient effort is going to be. Okay. And it uses a thing called expiratory flow cycling. So as the breath comes in, the flow will slow down up to a certain point, and then the ventilator will know it's time to exhale, okay?